Hi there, our highly valued, treasured and esteemed viewers and listeners, and welcome back to your channel of choice. This video I am about to present was compiled by Dr. Nath Arua, a clinical pharmacist by training and profession who is the founder of Progressive Pharmacotherapy Consultants, the premier virtual clinical pharmacy institute for capacity building for healthcare workers. The Virtual Clinical Pharmacy Institute with a difference, where patient safety, medication therapy management and optimal clinical outcomes are very crucial and non-negotiable to us. Here we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services. So, on behalf of the Institute, I humbly urge you all to sit back and spare me part of your very precious time to share with you very useful tips which may prove very, very handy in your line of duty. I now welcome you all to part 186 of our Pharmacotherapy MCQ series, which majors in infectious diseases. And the first question reads, TAW, a 27-year-old patient presents to your hospital. He has a past medical history significant for IV drug use. He is given a diagnosis of Candida glabrata tricuspid valve endocarditis. TAW is evaluated for valve replacement. The cardiology and surgical teams establish TAW is an unsuitable candidate for this procedure. So my question to you is, which of the regimens listed below would be the most appropriate for the medical management of TAW's infection? Would it be A. Amphotericin B for 6 weeks plus flucytosine for 2 weeks, followed by lifelong fluconazole suppression therapy, or B. Amphotericin B plus flucytosine for 6 weeks, followed by fluconazole suppression therapy for 6 weeks, or C. Amphotericin B plus fluconazole for 6 weeks, followed by fluconazole suppression therapy for 6 weeks, or would it be D. Amphotericin B plus flucytosine for 6 weeks, followed by lifelong fluconazole suppression therapy? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is D. Amphotericin B plus flucytosine for 6 weeks, followed by lifelong fluconazole suppression therapy. Combination therapy with amphotericin B plus flucytosine has been shown to decrease mortality compared with monotherapy in patients with native valve fungal endocarditis. In the absence of surgical intervention, lifelong fluconazole therapy should follow combination therapy. Combination therapy with amphotericin B plus flucytosine, not amphotericin B plus fluconazole, has been shown to decrease mortality in patients with native valve fungal endocarditis. Flucytosine should be continued with amphotericin B for 6 weeks as part of induction therapy in patients with native valve fungal endocarditis. Please advance to the next question. And the next question reads, which of the statements listed below regarding left ventricular assist device, abbreviated as LVAD-related infections is correct? Is it A. The Infectious Diseases Society of America guidelines for management of infective endocarditis recommend LVAD explantation for patients with driveline infections, or B. Empiric antimicrobial therapy for LVAD-related infections should target only Staphylococcus species, or C. Studies have demonstrated that administering antimicrobial prophylaxis targeting methicillin-resistant Staphylococcus aureus, MRSA, Pseudomonas species, and Candida species prior to LVAD implantation reduces infection rates, or is it D. Data are not available to suggest the optimal duration of antimicrobial therapy for management of LVAD-related infection. I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is D. Data are not available to suggest the optimal duration of antimicrobial therapy for management of LVAD-related infection. Data are not available to suggest the optimal duration of antimicrobial treatment for LVAD-related infections. The duration is usually based on expert opinion on a case-by-case basis. There are no studies demonstrating that antimicrobial prophylaxis prior to LVAD implantation reduces infection rates, although this practice is common. Empiric therapy for LVAD-related infections should target Pseudomonas species as well as Staphylococcus species, although this recommendation is based primarily on expert opinion. There are no guidelines for the treatment of LVAD-related infections. Many isolated driveline infections can be managed without LVAD explantation. Please progress to the next question. And the next question reads, PKS, a 57-year-old male patient presents to your accident and emergency department. His chief complaint and symptoms include foul-smelling urine, nausea, vomiting, and abdominal fullness that he has associated with urinary tract infections in the past. He usually undergoes catheter exchange every 4 weeks but missed his outpatient appointment 1 week ago. He has a past medical history significant for quadriplegia secondary to spinal cord injury, type 2 diabetes mellitus, hypertension, chronic sacral decubitus ulcers, sacral osteomyelitis, and neurogenic bladder requiring indwelling urinary catheter. On physical examination, PKS is afebrile, with a maximum body temperature of 99.0 degrees Fahrenheit, a heart rate of 75 beats per minute, a respiratory rate of 18 breaths per minute, and an SBP of 140 mm of mercury. PKS is admitted to your general medical ward, and a CT scan with contrast is ordered. PKS's current labs are as follows: a WBC count of 6 × 10⁴ cells per millimeter cubed, and a serum creatinine of 0.65 mg per deciliter. At baseline the value was 0.3 mg per deciliter. On admission to the general medical ward, PKS's catheter is exchanged. A straight catheterization urine sample is obtained. Urinalysis reveals 50 to 100 WBCs, 3+ bacteria, and fewer than 10 epithelial cells per high-powered field with a positive nitrite test. Urine culture gram stain reveals oxidase-negative lactose-fermenting gram-negative rods and oxidase-negative, gram-positive rods, with individual colony identification and susceptibility test results pending. So my question to you is, which of the pathogens listed below with the associated susceptibility should be reported to the Centers for Disease Control and Prevention National Healthcare Safety Network, abbreviated as NHSN, if cultured from PKS's urine? Is it A. Klebsiella pneumoniae sensitive to meropenem, or B. Streptococcus agalactiae sensitive to dorepenem, or C. Escherichia coli resistant to ertapenem, or is it D. Enterococcus faecium resistant to imipenem, celistatin? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is C. Escherichia coli resistant to ertapenem. Group B streptococci, i.e., Streptococcus agalactiae, do not need to be reported to NHSN. There are no reporting requirements for carbapenem-susceptible streptococci. Currently the only MDRs with CMS-mandated reporting requirements are MRSA and Clostridioides difficile. Escherichia coli resistant to ertapenem would qualify as a carbapenem-resistant enterobacteriaceae, which facilities should report to NHSN to contribute to national surveillance effort. Beta-lactam non-susceptible enterococci do not need to be reported to NHSN. There are no reporting requirements for carbapenem-resistant enterococci, such as Enterococcus fission. Susceptible Klebsiella do not need to be reported to NHSN. There are no reporting requirements for carbapenem-susceptible enterobacteriaceae. Please proceed to the next question. And the next question reads, this question applies to PKS's clinical scenario. If present, which of the following beta-lactamase genes would most likely warrant classification of PKS's gram-negative uropathogen as a carbapenem-resistant enterobacteriaceae? Would it be A, SHV1, or B, TEM1, or C, OXA48, or would it be D, CTXM15? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is C, OXA48. The CTXM15 gene confers extended-spectrum beta-lactamase production. However, it is not a carbapenemase, and an organism harboring only this gene would not be classified as a carbapenemase producer. The presence of CTXM15 alone is not sufficient to warrant reporting to the National Healthcare Safety Network as a lab ID event. The OXA48 gene encodes the production of an AMBLA class D carbapenemase. An organism harboring this resistance gene should be reported to the National Healthcare Safety Network as a lab ID event. The TEM1 gene confers low-level beta-lactamase production in Enterobacteriaceae, not serine carbapenemase production. The presence of Enterobacteriaceae with this gene need not be reported to the National Healthcare Safety Network as a lab ID event. The SHV1 gene confers low-level beta-lactamase production in Enterobacteriaceae, not serine carbapenemase production. The presence of Enterobacteriaceae with this gene need not be reported to the National Healthcare Safety Network as a lab ID event. Please progress to the next question. This question also applies to PKS. His past medical history and microbiology history are as follows: a urine culture history including Proteus mirabilis and Providencia stuarti with the following susceptibilities were previously reported. Proteus, with a ceftriaxone MIC equal to 0.25 mg per liter, and imipenem cilastatine MIC equal to 2 mg per liter, a nitrofurantoin MIC equal to 32 mg per liter, and a ciprofloxacin MIC equal to 2 mg per liter. Providencia with a ceftriaxone MIC equal to 0.5 mg per liter, and imipenem cilastatine MIC equal to 4 mg per liter, a nitrofurantoin MIC equal to 64 mg per liter, and a ciprofloxacin MIC equal to 4 mg per liter. Considering PK/PD principles, prior culture and susceptibility history, and antibiotic safety profile, which of the antimicrobial agents listed below would be the most likely to be effective for treating PKS's urinary tract infection? Would it be A, ciprofloxacin, or B, nitrofurantoin, or C, imipenem cilastatine, or would it be D, ceftriaxone? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is D. Ceftriaxone. Ceftriaxone achieves good urinary concentrations and is consistently active against the organisms that have grown in this patient's past urine cultures. Imipenem celistatine is inconsistently active against these organisms, and its use may result in poor outcomes due to the higher MICs exhibited by these organisms against imipenem celistatine. Nitrofurantoin is inconsistently active against these pathogens. Providencia is intrinsically resistant, in spite of good achievable urinary concentrations. Although ciprofloxacin concentrates well in the urine, it is also inconsistently active and its use may lead to therapeutic failure due to elevated MICs. Additionally, fluoroquinolones should be avoided for UTIs when patients have alternatives according to recent FDA warnings. Please advance to the next question. This question refers to PKS's case. PKS's urine culture ultimately spectates to Klebsiella pneumoniae and Enterococcus fischum with the minimum inhibitory concentrations MICs and susceptibility interpretations reported in the table in the next slide. I advise you all to pause the video and carefully scrutinize the table, which will be very useful in answering this question. So my question to you is, which of the antimicrobial agents listed below would be the best initial therapy for PKS? Would it be A. Ceftolozane, tazobactam, or B. Nitrofurantoin, or C. Ceftazidime, avibactam, or would it be D. Meropenem? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is D. Meropenem. Meropenem would provide coverage for both the extended-spectrum beta-lactamase producing Klebsiella and vancomycin-resistant Enterococcus fischum (VRE). The patient does not appear to require coverage for carbapenem-resistant Enterobacteriaceae at this time. Ceftazidime avibactam would be active against the extended-spectrum beta-lactamase producing Klebsiella, but it would not provide coverage for the vancomycin-resistant Enterococcus fischum (VRE). The antimicrobial spectrum of activity is excessively broad for the Klebsiella and not fully active against the VRE, causing this patient's urinary tract infection. Nitrofurantoin would be active against the extended-spectrum beta-lactamase producing Klebsiella, but it would not provide coverage for the Enterococcus. This VRE isolate would not be covered by nitrofurantoin due to resistance. The antimicrobial spectrum of activity is not fully active against the VRE, causing this patient's urinary tract infection. Ceftolozane, tazobactam would be active against the extended-spectrum beta-lactamase producing Klebsiella, but it would not provide coverage for the vancomycin-resistant Enterococcus fischum (VRE). The antimicrobial spectrum of activity is not fully active against the VRE, causing this patient's urinary tract infection. Please advance to the next question. And the next question reads, PKS completes a 10-day course of systemic antibiotics after his catheter exchange for a catheter-associated urinary tract infection, abbreviated as CAUTI. The urologist caring for the patient would like a recommendation for when to perform a subsequent urine culture in PKS's case. So my question to you is, which of the statements listed below describes the best evidence-based recommendation for screening for persistent bacteriuria in PKS's clinical scenario? Is it A. Screening for bacteriuria is recommended after completing 10 to 14 days of antibiotic therapy, or B. Screening for bacteriuria is recommended after completing a week of antibiotic therapy, or C. Screening for bacteriuria is not recommended if the patient is asymptomatic, or is it D. Screening for bacteriuria is not recommended if the patient intermittently self-catheterizes? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is C. Screening for bacteriuria is not recommended if the patient is asymptomatic. Screening for bacteriuria is not recommended for patients who are asymptomatic, regardless of whether they intermittently self-catheterize. 7 days is the recommended duration of antibiotic therapy for a rapid response in patients with CAUTI. Routine screening for bacteriuria is not recommended after completing 7 days of antibiotic therapy. A 10 to 14 day duration of antibiotic therapy is recommended for a slow response in patients with CAUTI. Routine screening for bacteriuria is not recommended after completing antibiotic therapy for this duration. So there you have it, our highly esteemed viewers and listeners. That brings us to the end of this video. If it benefited you in any way, kindly remember to give it a thumbs up, to like it and to share it widely with your peers. Please leave your comments at the bottom. And if you haven't yet done so, I humbly urge you to subscribe to our YouTube channel. I would like to promise you all that the very, very best is yet to come. Thank you very much for viewing this video. On behalf of our senior colleague, Dr. Nath Arua, I sincerely appreciate your partnership, continued support and kind collaboration. We look forward to interacting with you in the next video, which will be part 187.